screening is one of the main issues that we've identified within this trial. And we did an exercise with some of the sites. May remember that we did ask everyone to return their screening logs. And what we found that was the screening logs returned, some of them were okay, but some of them did not really actually capture the volume of patients you would have potentially seen who were eligible for the study. And we will, so Southeast have explored a few reasons behind what it could be with our own processes here. But before going into that, just to reiterate that efficient screening is quite important for any trial to be really successful. And one of the other reasons that we do the screening log is to, when it comes to study reporting and the quality of how the studies are reported these days, demand that we are very transparent with the potential number of eligible patients and the reasons why they have not been included in the study. And again, one of the other main point is to reiterate that our patient group is heavily involved in how we run this study, and they have repeatedly said to us, yes, we do like to make the decision ourselves. We do want to know about this trial. So if you do not capture them early or screen them efficiently, it is a missed opportunity for those patients who would have wanted to know about the study and make those decisions for themselves. So we do need to make a conscious effort to make sure patients are given the opportunity to participate in research. Again, earlier we mentioned about the problems in the consent pathway, how people have been given different information along the pathway. So if you identify patients early enough in the pathway with an efficient screening mechanism, that kind of controls that issue about equipoise and patients being given different information along the line. So that makes your life so much easier when it comes to consenting the patients. Obviously, and that in turn returns in possibly a higher rate of recruitment. And this study, obviously, we don't see so many of proximal humerus fractures which are 3 and 4 part. So it's quite important that we do keep our eyes open all the time and kind of not miss that one patient who might actually go into that that month. And it's quite important for the study at this point in time. Next slide, please. So what we did at Southeast was look at what we've been doing and kind of did a bit of a retrospective work going into all our systems and seeing, is it all that we see, was the question. Are we really reporting screening logs accurately? We did report quite a few numbers on the screening log, but we still, thought, as a site, we must see a bit more of these. And what we realized after doing a little bit of a retrospective exercise, going through different electronic systems and other pathways, was actually we've only reported 9 proximal humerus fracture, which are 3 and 4 part, along the months from August to December 2021. However, we would have, if we did a proper pre-screening log and a screening log, we would have found 51 shoulder fractures, and maybe quite a few of them, definitely more than 7, would have been potentially eligible, who may not have gone into the study, but at least we would have put them on the screening log. So we did realize that we need to do a little bit more work on why we're missing on these patients. And as part of this exercise, we realized the complexity was coming from the different pathways that existed within our Southeast. Multiple patient pathways are involved. Sometimes they just come directly from A&E to trauma, or A&E to virtual fracture clinics, or A&E to daily fracture clinics. And all of these meant that patients were coming through different pathways and not always highlighted correctly on the electronic systems. Sometimes they kind of said it was a shoulder fracture. Sometimes we just knew there was a fracture, but we didn't know which fracture it was, even on the system. And we were going by images at that point. So also reliance on quite a bit on clinicians to flag these potential patients from their clinics. Although all the trauma consultants were very well aware of the study and very well knew that the pathway was to make sure that they did not decide on the treatment pathway and send them on to a PROFHER-2 clinician. Even A&E had been flagged up to say that, all these patients potentially eligible should be flagged up to a PROFHER-2 clinician. it wasn't quite efficient all the time. And obviously, we know when it is a busy clinic setting, you easily quickly see and let them go, and doesn't always get followed through a PROFHER-2 clinician, or a research nurse doesn't get to know them. So that kind of posed a bit of a challenge. And Mark, one of our senior research nurses here, kind of thought, okay, we need to improve our mechanisms here, and what can we do? So Mark did a bit of an exercise in terms of putting a little bit of an effort on daily screening.